Thank you guys for joining us today. This is our third in our series for Critical Access Hospital CEO and CFO. It's our webinar series. Today, Jonathan will be speaking over the impact of the new RHC Reimbursement Methodology, the impact specifically on Oklahoma. And so if you have any questions as we go through the presentation, please feel free to share them. Please feel free to put them in the chat, or you have the capability to unmute yourselves as well. And so, Jonathan, with that, I will turn it over to you.
Thank you very much. And again, as Laura had mentioned, if you do have questions, please don't hesitate to submit them. I do want to make sure that I can address any questions that you have as we go through this information. Now, really, the purpose of the presentation today is to not only talk about what the change was around the RHC reimbursement methodology, but also talk about how specifically this impacts organizations going forward. Not only are fewer than 50-bed owned rural health clinics, that being hospitals of fewer than 50 beds that own RHCs, but also the independents and the greater than 50-bed RHCs. Now, when we talk about it through today, realizing that many of you are critical access hospital CEOs or CFOs, I'll also talk about from that perspective specific to those critical access hospitals and more around what this means for critical access hospitals going forward and how we can leverage this program in the future based on that change in the reimbursement methodology. Now, as we talk through the information today, again, as Laura had just talked about, there's different ways that this is going to impact organizations going forward. So as we talk through the information today, again, we're going to talk about that variance in the reimbursement methodology, but also the direct impact on organizations going forward and what this means for the state of Oklahoma as a whole. And again, with this change in the methodology, there are definitely winners and losers relative to the outcome when we're looking at the two reimbursement methodologies. Now, I'm not going to get into today the nuances of if this should have passed or shouldn't have passed. I'm just going to talk about what specifically this means for organizations going forward and how that will impact those organizations. So as many of you have probably seen, again, the RHC reimbursement methodology has changed. On December 27th of 2020, buried in the Consolidated Appropriations Act of 2021, roughly in that 5,000-page bill, there were about 6 pages dedicated towards materially changing the RHC reimbursement methodology going forward. Now, there really was two things that changed in that bill. One, it changed the upper payment limits attributed to RHCs that are truly independent, meaning that they're not owned or operated by any other entity, and also the RHCs that are owned and operated by hospitals of 50 plus beds. It materially changed those upper payment limits going forward. So prior to the passing of that bill, the RHC upper payment limit was about $87 in 2021. After the passing of that bill, that rate went up to $100 as an upper payment limit, and it's going to trend forward to $190 in 2028. Now, when we look at from a methodology perspective, the methodology for those practices remain the same. They are still subject to an upper payment limit, but what it did is it increased the upper payment limit itself. And that rate is going to more than double over the next 7 years. The second part of the bill of what it actually did was it changed the payment methodology for the RHCs that are owned and operated by hospitals with fewer than 50 beds from Medicare. Now, prior to the passing of that bill, all RHCs that were owned and operated by a hospital with fewer than 50 beds that was established as a provider-based RHC used to receive an uncapped cost-based reimbursement. Now, what I mean by uncapped cost-based reimbursement is if your rate was $200 this year, and again, assuming you met the minimum productivity standard, you would receive $200 from Medicare. If your rate went to $230 next year, you'd get $230. If it dropped down to $150 the year after that, you'd get $150. So every year that rate would rebase on your cost for that year per unit of service or per qualifying visit. Now, within that bill, what it did is it subjected all new RHCs and even those RHCs that are provider-based, owned and operated by hospitals with fewer than 50 beds to an upper payment limit going forward. Now, this slide up here does a good job of visually representing how RHCs will be reimbursed going forward. And I'll talk about in a little bit more detail about what actually happened with the changing of that bill. So assuming that all rural health clinics start over on the left-hand side, that farthest box to the left. Now, one thing I want to emphasize again, all RHCs going forward, doesn't matter if you are a fewer than 50 bed RHC, a greater than 50 bed hospital that owns an RHC, or an independent. All RHCs are subject to some form of an upper payment limit. It just is dependent upon what type of RHC you are and who owns you that will ultimately dictate that upper payment limit that you do receive. So starting with our independent RHCs, those RHCs, again, that are not owned and operated by any hospital or other entity, nothing changed for those RHCs relative to the methodology. They are still subject to that all-inclusive rate, that air-capped rate at the national limit. Again, the only difference is that rate went to $100 in 2021 and is trending forward to $190 in 2028, and then will increase by the Medicare Economic Index each year thereafter. Now, for purposes of framework, the MEI ranges anywhere, let's say, from 1% to 2% year over year. Now is where we get into our provider-based rural health clinics. And when we talk about our provider-based rural health clinics, you have provider-based rural health clinics that are owned and operated by hospitals with 50 plus beds or fewer than 50 beds. Again, if you were a rural health clinic owned by a hospital with 50 plus beds, there is no change in the methodology. The methodology remains exactly the same. The difference is the upper payment limit that you are subject to. Now, where the change in the methodology really comes into effect, and this is specific also for our critical access hospitals, is RHCs that were owned and operated by a hospital with fewer than 50 beds. And the law that was passed, that Consolidated Appropriations Act of 2021, ended up creating a grandfathering provision in that bill or in that law. Now, if you are an RHC and you were enrolled in Medicare, that is, you became an RHC after 12/31/2020, or you submitted your application to become an RHC after 12/31/20, you will now be subject to the same upper payment limit as the independents and those hospitals that have 50 plus beds that own an RHC. So no longer will you be able to get a rate that is established either at your cost-based rate or at your true cost-based reimbursement going forward. Now, for the other RHCs, if you were a hospital with fewer than 50 beds and you owned an RHC that was enrolled in Medicare prior to or on 12/31/2020, or you had submitted an application to become an RHC prior to that date, you will be considered a grandfathered RHC from a payment perspective. And if you are a grandfathered RHC, then your rate will be based on your 2020 all-inclusive rate from your cost report, increased by the Medicare Economic Index that year after. So what I mean by that is if your rate was $200 based on your cost report in 2020, and there was a 1% MEI increase, your rate would go to $202 as an upper payment limit. Now, I just want to emphasize again that this is a change in the payment methodology. So gone are the days of cost-based reimbursement. Going forward, you will now receive a reimbursement that is the lesser of your true cost-based rate or that upper payment limit. And what I mean by that is if your cost-based rate is $100 and the upper payment limit is $113 like it is this year, you'll get the $100. If your cost-based rate is $150 and the upper payment limit is $113, you will get the $113. Now, the same holds true for those grandfathered RHCs. If you have an upper payment limit set at $200 and your true cost-based rate is $185, you'll get that $185. If your cost-based rate this year were to go up to $225 and your upper payment limit that was set is $200, you will get the $200. So this is always, you will get the lesser of that upper payment limit or the cost-based rate. Again, the lesser of the two. And the reason why I want to emphasize this a couple different times is for our critical access hospitals, this is truly a change in a methodology of how we are being reimbursed as critical access hospitals going forward. This program is no longer truly a cost-based program for our rural health clinics that are owned and operated by hospitals of fewer than 50 beds. And to think about it from a payment methodology perspective, when we evaluate this program going forward, think of it like a next-gen ACO or some type of program where it is solely an at-risk type program going forward. What I mean by that is when we look at at-risk or downside risk, if you're controlling your cost, you will be able to get your cost-based reimbursement. However, if your cost increases at a greater rate than the MEI, you will lose out on those reimbursements from Medicare. So again, it is truly a at-risk type program going forward if we're not able to operate efficiently and effectively and control our costs going forward. Now, when we look at Oklahoma as a whole, based on the 2020 Provider of Services file, Oklahoma had about 100 RHCs across the entire state. There's actually a typo on there. I apologize for that. When we look at our RHCs across the state, the overwhelming majority of those RHCs are actually hospital-based RHCs. And when we look at from the perspective of hospital-based, again, that means they are owned by any type of hospital from that perspective. Now, when we look at 2020 and we look at all the new RHCs that were established, there were 13 new RHCs established in 2020, and the overwhelming majority of those were provider-based rural health clinics. Now, when we also look at 2020, particularly for our critical access hospitals, there were 25 critical access hospitals across the state that owned 50 rural health clinics. So almost 50% of all rural health clinics across the state are owned by critical access hospitals. Again, a program that is no longer cost-based and subject to an upper payment limit going forward. Now, when we look across all of our RHCs as a whole, and again, look from the perspective going forward, we can look that in 2015, we had a decline in the number of clinics as we're looking forward through 2020. Now, in 2015, we had 31 provider-based rural health clinics, and we saw that number increase to 82 rural health clinics in 2020. So again, overwhelming majority of the rural health clinics in Oklahoma are provider-based rural health clinics. Now, when we look at our hospital-based rural health clinics, those that are 50 plus beds, we saw an increase in the number of RHCs also from 2 to 4. But nonetheless, we have seen an overwhelming increase in the number of RHCs when we're looking at our provider-based rural health clinics. And then when we look at our independent rural health clinics, we've seen a slight decline from that perspective of looking at those going forward. Now, nonetheless, across the state as a whole, we have seen an increase in the number of rural health clinics, even though those that are subject to that upper payment limit, we have seen a slight decrease in those number of clinics. So again, when we look at the provider-based rural health clinics, those that used to be subject to a full cost-based reimbursement, we've seen a 165% increase in our cost-based RHCs. For our RHCs that are subject to an upper payment limit, we've actually seen a 5% decline in those number of RHCs, dropping from 20 down to 19. Now, when we look at the framework and how this bill will end up impacting the state as a whole, we can see that, again, the overwhelming majority of our RHCs are provider-based rural health clinics that will now be subject to that upper payment limit going forward, regardless of whether it's a grandfathered upper payment limit or the true new upper payment limit going forward. Now, what you'll also notice too, when we're looking in 2015, you can see there's a couple of years where the cost reports is greater than the number of clinics. Now, the reason for that is we ended up pulling the Provider of Services file. And we looked at the number of clinics that were in operation at the end of the year. For the cost reports, now, even if you were to terminate a clinic within a given year, you had to file a year-end cost report or a closing cost report for that clinic. So if we look at 2015, the reason there were 2 clinics for the hospital-based, but 3 cost reports is because a clinic had actually closed and you had that cost report, but not the clinic at the year end. Now, the next slides that we're going to be looking at is the distribution of clinics across the state as a whole and how this will impact those organizations going forward. I'll also identify certain opportunities that we can take, again, to hopefully lessen the burden that we will realize from the fact that this change in the reimbursement methodology will start hitting our clinics. Now, when we look across the state as a whole, this slide ends up looking at the actual visits across all of those clinics. Now, one thing I want to emphasize is all of the data that's coming out of these future slides is based on the cost report data that was filed on the 2020 cost report. So there are many clinics that consolidate cost reports and roll that information up. So that is why there are not as many slots on the chart. And that's also why we end up having a clinic that looks like there's 85,000 visits. There is no single clinic within the state that has 85,000 visits. Again, that's because of the consolidation of those cost reports. Now, when we look across the state as a whole, again, we can see that the overwhelming majority of the visits does happen on that provider-based rural health clinic side. Now, there is one independent rural health clinic that does have about 35,000 visits, which is a great size for an independent clinic. But nonetheless, we look across the spectrum and we can see the overwhelming majority is, again, on that provider-based rural health clinic side. Now, this is also in a visit count, but this is also in the number of clinics themselves across the state. Now, what this slide looks at is this looks at the average cost per visit, and it compares that average cost per visit to what the clinics would have received in an adjusted visit perspective. Now, under the Rural Health Clinic program, Medicare uses the greater of your actual visit count or the adjusted visit count to determine what your reimbursement is per unit of visits for that RHC. Now, when we look across all of the clinics, those rural health clinics had a total cost of about $134 million across the state, with the distribution being about $119 million for the provider-based rural health clinics and a little bit under $15 million for the non-provider-based rural health clinics. Now, when we look across and we look at the actual visits, those provider-based rural health clinics had about 513,000 visits. So the average cost per visit was about $232 per visit. Now, again, based on all of the FTEs that were entered into all of those different cost reports, it come up with the adjusted visits for all of those RHCs. And the adjusted visits was about 544,000 visits. So again, those RHCs missed the minimum productivity threshold by about 30,000 visits. So the adjusted cost per visit was about $219. So the collective of all of the provider-based rural health clinics across the state ended up losing out on average about $13.44 in cost-based reimbursement because of the failure to achieve that minimum productivity threshold. Now, one thing that's also interesting when we look at the year of 2020 is Medicare came out and actually allowed a COVID waiver, where because of the pandemic, we could have filed paperwork with the MAC and end up getting a waiver to the minimum productivity thresholds because of the COVID pandemic that impacted the ability to staff our clinics and also provide those services. So the fact that we had many of our clinics still missing that minimum productivity threshold, even with that waiver in effect, highlights that we did have some clinics that missed out on the opportunity and are missing out on reimbursements because of not achieving that waiver or pursuing that waiver. Now, looking at our non-PBRHCs, even though those clinics are subject to an upper payment limit, it's still important to look at whether or not they achieve that minimum productivity threshold across those clinics. So again, about $15 million in cost, 98,000 visits. The average cost per visit was about $148. However, when we adjust based on the minimum productivity threshold, they should have had about 103,000 visits. So the adjusted cost per visit was about $142. Now, if they were fully cost-based, they would have lost out on about $7 per visit. Now, when we look at the bottom table there, what we also ended up looking at is those clinics that are truly independent versus those that are hospital-based. And the reason we separated those out is because our hospital-based rural health clinics pull down a certain amount of overhead expenses. Again, A&G costs, facility costs, all of those other costs that steps down to those clinics. So what we wanted to look at was how that ended up impacting the distribution of cost and the cost per visit for those different clinics. Now, again, because we do not have that many rural health clinics that are owned and operated by hospitals with greater than 50 beds, there was not much of an impact on the distribution between those visits and that reimbursement rate. Now, the next slide looks at the RHC cost per visit. Now, when we look across the overwhelming majority of the clinics within the state of Oklahoma, we can see that the overwhelming majority of those clinics had an average cost per visit that was less than $250 per visit. Now, you're probably looking at the screen and saying, whoa, what is that clinic with $1,100 per visit RHC cost? That's what I would like to have as my rate. Now, I will emphasize that that clinic was a brand new clinic. It was their first year of operation, so they had a significant amount of cost, but they did not have a good number of visits to help offset that cost. So they would end up normalizing in year two because of having a full year of operations, but also a full year of visits. Now, it's also important to note that this is looking at the RHC cost per visit and is not necessarily the reimbursement rate that they received for those different practices. Again, because you get the lesser of your cost-based rate or the adjusted cost-based rate if you fail to meet that minimum productivity threshold. Now, the next slide, what we're going to look at is this looks at the net impact or the potential lost reimbursements by the state of Oklahoma due to not achieving that minimum productivity threshold. Now, again, when we look at our independent or our greater than 50 bed clinics, those clinics were always subject to an upper payment limit. So when we talk about the lost reimbursements for those clinics, it's looking truly at lost reimbursement relative to cost. They would not have received their cost-based reimbursement in that prior environment from that perspective. Now, when we look at our Medicare reimbursement for our provider-based rural health clinics, there was about $33 million in reimbursement and 147,000 visits. So we received about $222.11 as an average reimbursement across all of those visits. However, our average cost per reimbursement was about $233. Again, we lost out on that reimbursement. So the net impact was about a $1.6 million loss in reimbursements because the clinics as a collective did not achieve that minimum productivity threshold. Now, as you may remember earlier, it was about a $13 difference on the prior slide. The reason for the slight variance on this slide is when we did the analysis, we calculated the analysis independently and across every single clinic. So what we looked at was we looked at the volume fluctuations, we looked at the direct Medicare visits, we looked at all of those different factors so we could truly calculate the net impact, not only on each clinic, but the collective of all of the clinics. For our non-PVRHCs, again, received about $2.9 million in reimbursement, about 34,000 visits. So they got an average reimbursement rate of just under $86. But again, their cost was about $149. So what this also highlights is the fact that for our independent and our hospitals with greater than 50 beds that owned RHCs, you cannot sustain yourself in a long-term environment when we're looking at the fact that we were receiving that low in reimbursements of about $85, but our actual cost per visit was about $149 per visit. So again, there needed to be some type of change from that perspective going forward. Now, the next slide looks at our average reimbursement across all of those different visits. Now, we can see that the rates fluctuate all over the board, with our provider-based rural health clinics having a rate that was cost-based and our non-PBRHCs being subject to that upper payment limit. And we can see that that highest reimbursement rate actually received was around $500. Now, again, that was that same clinic that had significant upfront cost, but the rate was actually chopped down for failure to meet that productivity threshold. Most of our rural health clinics that are cost-based across Oklahoma average out about $200 a visit. So again, not a huge outlier from that perspective. Now, when we wanted to calculate the impact across all of the different rural health clinics, what we wanted to look at was say, with the fact that the RHCs going forward are going to be subject to a Medicare Economic Index, how does this relate to the actual cost increases that those different clinics are experiencing? And looking at from the perspective of saying, okay, if we are subject to, say, a 1.5% Medicare Economic Index, but our cost is increasing at a greater rate, how will that impact our organizations going forward? Now, first, what we wanted to look at was our provider-based rural health clinics. So what we did is we looked across all of our provider-based rural health clinics and we calculated the average annualized cost increase across those different clinics. And we can see that their rate was about $165 in 2015, and it trended forward to about $232 in 2020. So all of those collective of clinics experienced about a 7.1% increase on an annualized basis looking across that 6-year period. For our non-PBRHCs, again, they started at about a $104 rate and increased to about $149. So they experienced about a 7.4% increase over that 4-year period. Now, it's interesting to note also that our non-PBRHCs experienced an annualized increase that was actually greater than our PBRHCs looking forward. So what will this do in the way of reimbursements, and how will this impact organizations going forward? So what we wanted to do was we wanted to model off based on our 2020 adjusted cost-based rate and trend that forward based on an average annual increase in expense, and then also comparing that to that upper payment limit. Now, what we did is when we ended up increasing the cost, we looked at about a 3% annual cost increase for both the provider-based and the non-provider-based RHCs. And the reason for that is we assumed that with a change in the reimbursement methodology, there was going to be some type of normalization in those RHC expenses going forward. But nonetheless, when we increase that provider-based rural health clinic rate, the expense is 3% per year, the rate would go from about $222 up to $281 as an average visit. However, if we were to increase or subject those clinics to that new upper payment limit going forward, again, a 1.4% MEI, that upper payment limit in 2021, if it went up 3%, it should have been $228. At 1.4%, it's only $225. Trending forward all the way to 2028, if we continued increasing that rate again by 3%, we should be at $281. But at 1.4%, we're only at $248. So the collective of the RHCs in Oklahoma that are provider-based would lose out on about $33 in reimbursements across the average of those visits. For our non-PBRHCs, again, those that were independent or owned by hospitals of fewer than 50 beds, the adjusted cost-based rate in 2020 was about $135. Increasing that forward again by 3%, that rate would be about $171 in 2028. But what we did is we compared that to the prior capped rate, which was about $86 in 2020. and increase that by the 1.4% to that new reimbursement methodology. Again, that started at $100 in 2021 and trends to $190 in 2028. So in 2021, for those non-PBRHCs, the adjusted cost-based rate was $139. Under the old methodology, they should have got about $87.52. Under the new methodology, they got $100. So again, those clinics stand to gain about $12.50 in 2021, trending forward all the way to 2028, they're going to gain on average about $74 per visit. So when we look at the reimbursement methodology, we can really look to the fact that by controlling the cost increases on the one side, those PBRHCs allowed us to cover the cost increases on the other side. So if I were to ask everybody attending the presentation today, and we could just think about this internally or quietly, because the overwhelming majority of our clinics in the state of Oklahoma are provider-based rural health clinics that used to receive cost-based, and the rate is capped going forward, do we think that Oklahoma is going to be better or worse off if we were to all experience those 3% cost increases going forward? So hopefully everybody is guessing or would realize that we would actually be worse off as a collective of a state because of this change in the RHC reimbursement methodology. So again, when we look across all of those clinics, we assume that the clinics would experience, again, a 3% cost increase going forward. Now, when we look at those RHCs going forward, in 2021, under the old methodology, the collective of those RHCs should have received about $229. Under the new methodology, they're going to receive about $225. So those collective PBRHCs are going to lose out on about $524,000 in reimbursements. The non-PBRHCs, under the old methodology, would have gotten about $87 a visit. And the new RHC methodology, they're going to get about $99. Now you're asking probably, why is it $99 and not $100? And again, because the way the RHC reimbursement methodology works, you get the lesser of the upper payment limit or your cost-based rate. And there were some independent RHCs that had a cost-based rate that was below that $100 rate, which is why they are getting less than the $100. Now, when we average the two together, add the two together, the state of Oklahoma as a whole is going to lose out on about $128,000 in reimbursements in 2021. Again, the independents are going to gain about $400,000. The provider-based will lose about $523,000. Now, again, this is taking into account that those clinics will experience a 3% annual cost increase. If the cost increase is greater than 3%, then the loss or potential loss in reimbursements would be greater. If the expense is less than 3%, then that net impact would go down from that perspective. Now, one thing I also want to emphasize about this slide is it's only comparing the difference in the two reimbursement methodologies. It's not looking at the net financial performance of a clinic itself. So from this perspective, these clinics could still be hugely profitable. Again, it is only looking at the difference in reimbursement itself. Now, in 2021, we're going to lose out on about $128,000 in reimbursements. As we look forward and go all the way through to 2028, again, adding up all of the impact of the reimbursements over the years, our PBRHCs are going to lose out on almost $5 million in reimbursements under the new methodology when compared to the old methodology. And the independent RHCs are going to gain about $2.5 million. But nonetheless, the state as a whole, when we add this up, the state as a whole from a Medicare perspective is going to lose out on about $2.4 million in reimbursements as a blend. Now, looking at the fact that many of us are critical access hospitals and many of us are true safety net providers for our rural communities, if we were to divide this out across all of the hospitals across the state, Could any of you sustain losing $300, $400, $500 a year in reimbursements by the time you get out to 2028? So what ends up happening is we've put ourselves in an environment because of this change in the methodology where we really have to work to control our costs going forward. I'm going to pause for a second to see if there's any questions maybe I can answer before I go into the next couple slides and talk about different ways or different things that we must start looking at or factoring in to help offset or combat the fact that we are now subject to an upper payment limit. All right, not seeing any questions. So what can we do as organizations going forward? For specifically our critical access hospitals, gone are the days for our rural health clinics where we are truly getting cost-based reimbursement. Even in the best environment, we will be subject to our grandfathered upper payment limit going forward as a rural health clinic. So what we need to start doing, particularly as critical access hospitals, is we really need to start evaluating the operational performance of those different clinics going forward. And there's many different things we can focus on. We could be focusing on the FTEs allocated to our RHCs. Again, are we leaving money unnecessarily on the table because maybe we're overstating the FTEs attributed to our RHCs? Now, again, for our rural health clinics, for every one FTE physician, they need to see 4,200 patients per year. And for every one FTE APP, they need to see 2,100 patients per year. Now, the FTE calculation, we only include the time that they are scheduled to see patients in the clinic. So just because we have a one FTE physician does not mean that we put a 1 on the cost report. We have to reduce down the administrative time, reduce down the CME time, reduce down if they're taking holidays, vacations, sick. All of that time reduces down. Same thing for our APPs. It is only the time that they're scheduled to see patients in that clinic that we should be reporting the FTEs. What else can we do from a perspective to trying to control costs? Now, the reason why I'm also emphasizing a couple of these different points is I don't know many clinics, if really any clinics, that are able to control their annual cost increase to the Medicare Economic Index. So even if we're able to control our cost to 2%, if the Medicare Economic Index is only 1.4%, we are still going to lose out on the potential 0.6% reimbursements relative to our cost because of the fact that we are subject to that upper payment limit going forward. Other opportunities that I would say that we really need to start working on is, most importantly, is starting to track the data as a whole. Looking at how we can leverage the information to start tracking certain KPIs relative to our rural health clinics. Now, up on the slide right now, we have some information pulled from LilyPad. And I know that this is a program that is available within the state, and it allows you to track all of your rural health clinics' performance looking at several different factors. Now, in addition to also looking at the FTEs, we also need to start looking at additional opportunities around throughput, appointment times, scheduling, additional revenue opportunities. Are we doing our CCMs, TCM, BHI? Are we doing our annual wellness visits as actual scheduled visits, or are we still just piggybacking those on when a patient comes in and only billing out for that single visit per day? Are we having our providers operate at the top of their license? If we can have an MA do certain functions, does it make sense to have another provider do a certain function that costs more if an MA can provide those services within that capacity? So what we need to really start looking at is start looking at different ways that we can control our cost relative per unit of service. Now, one thing I also want to emphasize too is this is not just a matter of cutting cost within the clinic. Because we look at the total cost divided by the total visits, we can also increase our visits relative to our cost as a means to continue to control those cost increases going forward. So again, leverage all of these additional opportunities, track the data, get in there and really look at different factors as a way that we can start controlling our costs from that perspective going forward. We also need to continue to look at additional revenue opportunities, whether it's 340B or looking at additional things such as that. We also need to continue to evaluate the designations and alignments of our practice. Maybe in the past, the rural health clinic was the most advantageous program for us. However, we have an on-campus practice and a very productive provider. Maybe it would be better to make that a truly provider-based clinic and separate out the billing and go back to that perspective as a critical access hospital. Really, what I want to emphasize is with the change in the reimbursement methodology, we can no longer apply it from a status quo perspective because of them getting rid of that cost-based reimbursement. So I know I've gone through a ton of different information quickly, and I wanted to leave, because we're talking about changes in reimbursement methodologies and different factors, I wanted to leave a good 10 to 15 minutes left to see if there were any questions I could answer relative to the change in the reimbursement methodology, relative to the change in how this will impact critical access hospitals going forward, or any of those different factors. So I'm going to pause to see if there's any questions that I could answer.
Hey, Jonathan, this is Laura. I'm not seeing anything come through in the chat, but this might be a good time to kind of bridge over to our May 3rd webinar with Greg, talking about quality in the clinics. And I know you're going to be one of the presenters on that panel.
Yeah, so when we start talking about quality within the clinics, I know Greg is going to be presenting on certain quality and really key questions that we need to start asking ourselves within a rural clinic setting relative to productivity, performance, providers to APP coefficients, all of these different factors that'll end up playing into it. And again, what we need to do is start looking at different operational opportunities, and Greg's going to highlight many of those opportunities to say we have to start looking at operational opportunities, again, to look at how we can control the relative cost per unit of service and use that as a means to ensure that we get the maximum reimbursement from that perspective, because we are now subject to that upper payment limit. The tool that he's going to talk about, I mean, frankly, I think it's a very well-established tool, and it provides a lot of great information. And it's really something that you can leverage as a means to really start to look at the productivity and the performance of your individual RHC. And I think, Laura, you guys fund it, and it's available to everybody in the state, correct, from an RHC perspective?
Yes, it is. So if anyone has questions about Pond or would like to get signed up, or if you're not signed up, please reach out to me. I'll help get you hooked up with that. We are one of the states that's participating in the RHC QI project. And so we have, I know Melinda's on the call, and then our cohesive folks. So we have some of those folks who are piloting that for us on the call today. So,
hey,
all
Laura,
right. Yes,
Laura,
right.
is Lake Area Medical Associates on that?
You guys are in Pond, but you're not in the QI project that we had going on at the moment.
Did can you send me some details on that?
Yes, I can.
But again, it's a free well, it's not free to somebody. I mean, Laura's paying for it as a part of her funding, but it's free to all of you as RHCs or entities that own RHCs to leverage that data. And it's great from the perspective that it is solely dedicated to RHCs. So you can benchmark yourself to other RHCs relative to cost per physician and looking at all of these different factors, realizing that RHCs do have different requirements and they're different services that we provide. And it does allow you to benchmark yourself to those other RHCs. So not seeing any other questions, I'm going to turn it back to Laura.
Well, thank you. Just one quick announcement. We are recording this call, and once it is posted on the YouTube link, or YouTube channel, I will be sure to send the link out to everyone. Also, our next webinar is scheduled for April 12th at noon. And it's going over the cost report, the impact of the cost report on decision making, and Zach will be presenting that day. If you have any questions following this webinar, please don't hesitate to reach out to me. And Jonathan, thank you for your time and thank you for joining us today.
Thank you very much. Everybody have a great day.